So I'd like to start with a 15th century philosopher by the name of Niccolo Machiavelli, who stated that there is nothing more difficult to carry out, nor more doubtful of success, nor more dangerous to handle than to initiate a new order of things. Well, what's the new order in cardiovascular medicine? The first is that atherosclerosis is no longer considered to be simply a bland cholesterol storage disease. It's much more dynamic than that. The root cause of atherosclerosis is actually the retention of ApoB lipoproteins, followed by a maladaptive and, may I add, deranged inflammatory response. That the vast majority of atherosclerotic plaques that rupture and lead to acute events are not what we thought. They're not the 80-90% obstructive lesions that go on to 100%. They're non-stenotic, highly inflamed plaques that suddenly rupture. And another important point to remember is that although cardiovascular intervention, whether it's catheter or scalpel-based, is of utmost importance in the unstable patient with an unstable ischemic syndrome, but in stable coronary artery disease, intervention has not been shown to prolong life or prevent future heart attacks compared to medical therapy. And most importantly, that therapeutic lifestyle intervention, which we're going to be discussing this morning, and optimal medical therapy is actually the best approach to treat, to prevent, and indeed to reverse atherosclerosis. Now, I'd like to start this morning by having everybody put down your coffee cup and turn and look at the person sitting right next to you. Look them right in the eye. Because one of you is going to die from this condition right here. One of you will die from that condition. And what's this condition? Well, here's an atherosclerotic plaque that's ruptured with an occluding thrombus, and it snatches people out of the prime of their life. Happens in this country every 20 or 30 seconds, often without warning. And what we are doing over the next 4 days is gathering together some of the brightest clinicians and researchers around the country and around the world who will be discussing how to prevent this disease. And it is preventable, because it's not inevitable that cardiovascular disease is going to be the number one cause of death for men and women going forward. And why is that? Because we're at the dawn of a new era in cardiovascular medicine, an era where we no longer just spring into action once a plaque ruptures and try to bail patients out, but an era where we can prevent this disease. We could stabilize plaques. We could actually achieve plaque regression. We can take this ferocious lion, which we call cardiovascular disease, and reduce it to a harmless pussycat. Well, who is this gentleman right here? I think a lot of you remember Tim Russert, who was a very dynamic political news reporter for NBC. And one day in the newsroom, 1:30 in the afternoon in New York, he clutched his chest, fell off his chair, and dropped dead. Had a heart attack, ruptured a plaque, sudden cardiac death. Everybody was aghast. How could Tim Russert drop dead? His doctor had him on statin, and his cholesterol, his LDL, was less than 70. And his stress test was normal, done a couple months ago. Well, we now understand that Tim Russert is the poster boy of residual risk, which we'll be discussing. How could we take additional risk off the table? I mean, he had mild elevation of his triglycerides, a low HDL, he had some features of insulin resistance, a big belly. We know what happened to Tim Russert. Even though his LDL cholesterol was normal, he was showering his vascular wall with small, dense LDL particles. And this chronic exposure to atherogenic particles over time can eventually lead to what I'm going to show this morning. Well, there are a lot of women here, and how about women and cardiovascular disease? Now, women are somewhat protected up until menopause. And you can see by this graph right here that there's a spike in women around menopause. The blue line's death from heart attack. The yellow line is death from stroke. It dwarfs other causes of death in women, from breast cancer to colorectal cancer to endometrial cancer. So we have to pay attention to this disease. And on Saturday, we're going to have a special session devoted to women's health and cardiovascular disease. But I think what we'll do to start out this meeting is review the vascular biology of atherosclerosis. It's important that we understand this. And the first statement I'm going to make is that there is no such thing as a good cholesterol or a bad cholesterol. We've been hearing this for years, for decades. What's your bad cholesterol? What's your good cholesterol? Now, there are particles that carry cholesterol that are potentially punitive, and there are particles that are potentially protective. And the potentially punitive particles are ApoB particles. They're lined with ApoB 100, in the case of chylomicrons, ApoB 48. They include LDL, which is 90% of the particles in our circulation at any given time, but also Lp(a), which we'll be discussing later, and remnant lipoproteins, and especially triglyceride-rich remnant lipoproteins are the new kid on the block because they get into the vascular wall and create havoc. As well as all of these particles can go through a porous vascular wall, except for the very largest chylomicrons and VLDL. It's an ebb and flow all day long, and it's driven by concentration of these particles. Down here we have HDL particles that don't have ApoB, they have ApoA1, and HDL is not always good, the good guy. You could have dysfunctional HDL, and we'll be discussing that as well. But here's how it works. We have these particles, and these atherogenic particles get into the vascular wall. They get trapped and retained. And like sharks sensing blood, when these particles get retained and modified, our monocyte foot soldiers say there's something wrong, we're being attacked. And so they enter the vascular wall and become macrophages and engulf the enemy. And then they do something that is truly maladaptive. They don't leave. It's like the Roach Motel. They check in, but they never check out. They don't behave like a normal dendritic cell. And not only do they stay, but they contribute to all aspects of the plaque, from initiation of the plaque, to the progression of the plaque, to the subsequent rupture, and then to the thrombosis. They release three very important noxious substances. One is lipoprotein lipase, which enhances further retention of these particles to proteoglycans. They release matrix metalloproteinases that break down the collagen that lines the plaque, weakening the plaque, making it just a setup for rupture. And they release tissue factor, an intense procoagulant, which along with activated platelets ensures robust clot formation once the plaque ruptures. At the end of the day, what we have is this is from the Quebec Cardiovascular study, and we know that when we have too many atherogenic particles, we increase risk. If they're small, dense LDL particles or any of the other particles, we increase risk sixfold. If we have, don't think for a minute that large particles are your friend, because they're not. And the phenotype of large particles is FH, familial hypercholesterolemia, where we see premature atherosclerotic vascular disease. So it really is not so much as are the particles large or small, are there too many particles, because too many particles will enter the vascular wall. And if that happens over a lifetime, the chronic exposure to the vascular wall of atherogenic lipoproteins is what leads to premature atherosclerotic cardiovascular disease. And our job as preventive physicians is to reduce the number of atherogenic particles. We've identified the enemy, and this is the enemy. And if we can decrease the number of ApoB lipoproteins, we significantly lower risk. The other problem we have today is we live in a world of obesity, insulin resistance, and sick fat. And it's led to what we call discordance. Discordance is when you have a normal LDL cholesterol, and yet the patient still goes on and develops disease. There's a discordance between LDL cholesterol and the number of these atherogenic particles. Where do you see that? Well, we see that predominantly in a setting of insulin resistance. So here's two patients. They both have an LDL cholesterol of 100, okay? Here's Sam over here, and Sam is a healthy guy. They're both 45 years old, both of these gentlemen. Sam exercises on a regular basis. He watches his diet. He certainly makes sure that he stays away from cigarette smoking, and he's just the picture of health. And here is Max. And Max has got a big belly. You know, he says, yeah, I'd like to exercise, but I'm busy. I got other things to do, so I often eat the fast food and processed food. But he says, but not to worry because I exercise. Oh, really? What do you do? Well, I play golf on the weekends. And further questioning, he rides in a cart, and he's always accompanied with a Coca-Cola and a bag of potato chips. And of course, he has a lot of small dense particles. In fact, he can have up to 70% more particles than Sam. Now, who do you think is more higher risk of developing an event? Lifestyle. This all stems from lifestyle. Yes, there are genetic causes that we'll talk about, but the major driving force of too many small dense particles that lead to atherosclerotic plaques and lead to disease and lead to sudden cardiac death and lead to the Tim Russerts of the world are the patient who follows a flawed lifestyle and ends up with an unstable plaque. Now, is there data to show that measurement of these particles? You can measure them two ways. You can measure the totality of ApoB particles by getting an ApoB blood test, ApoB lipoprotein, or you can get an LDL particle number, so-called LDLP. Well, this was a study by Cromwell and colleagues that showed that if your LDL particle number is low, your risk is low, and it doesn't matter whether your LDL cholesterol is high or low. Conversely, if your LDL particle number is high, your risk is high, and it doesn't matter what your LDL cholesterol is. So you should get a stone and carve this on stone and put it on your desk. When LDL cholesterol and LDL particle number are discordant and they don't match one another, one is high, one's low, risk tracks with particle number, period. Very important that we understand that. In fact, this study, which just recently was published, called the Cardia study, was very informative because the Cardia study basically looked at young adults with elevated levels of ApoB, okay? Young adults. And they followed them over 25 years. And they found that those individuals with elevated ApoB levels were more likely to develop atherosclerosis than those who had LDL cholesterol or even non-HDL cholesterol that was normal, okay? So there's discordance not only with LDL cholesterol, but also with non-HDL cholesterol, and it's especially in our obese, insulin-resistant population. Now, I'll be the first one to say that non-HDL cholesterol is a better marker of risk than LDL cholesterol, but they're all surrogates of particle number. That's what's driving this disease. This was an interesting commentary by Peter Toth and Alan Snyderman, who stated that they looked at causal exposure paradigm versus the risk paradigm. Today, our cholesterol guidelines look at risk. But they, I think, correctly point out that clinical studies of individuals genetically predisposed to modestly lower LDL cholesterol over a lifetime have a much greater reduction in cardiovascular disease. Well, who are these individuals that are genetically predisposed? These are people with loss of function mutations of PCSK9, loss of function mutations of NPC1L1, where we see a mild reduction in LDL cholesterol, and it's over a lifetime because they were born with this, but that translates into a huge benefit in the case of PCSK9, up to an almost 90% reduction in cardiovascular disease risk. Why? Because you're taking away that chronic exposure to the vascular wall to these ApoB particles. And over a lifetime, that's important. So he goes on to say that these genetic data strongly support the hypothesis that preventing atherosclerosis before the development of disease is likely to be more effective than reducing LDL when vascular disease is advanced. That's a very important concept because I've always felt that if we could spend a couple dollars, getting an ApoB blood test is very inexpensive. If you don't want to do that, at least, my gosh, get a non-HDL. And if you have young people that don't have any evidence of atherosclerosis, my gosh, let's prevent it. Let's get those numbers normal because we know those numbers are linked to the development of atherosclerosis. How do we do it? Mainly through lifestyle intervention, and we'll be discussing that this morning. If that fails, we have wonderful medications that can get us to the promised land. So at the end of the day, we have vulnerable patients. And what's a vulnerable patient? It's a patient with vulnerable blood who develops a vulnerable plaque, an unstable plaque. And like members of a bomb squad, our charge is to defuse these bombs all throughout the body, in our coronary arteries, in our brain, in our periphery. Because by doing that, we can convert a vulnerable plaque into a non-vulnerable plaque, and an unstable plaque into a stable plaque. And how do we do that? We correct all the metabolic derangements that we identify, and especially those metabolic derangements that we see when we do blood tests. And I think that's really the winning strategy to keep people protected, not to wait for disease to strike. The other mistake is to assume that what we've done for decades, that, my gosh, Papa's got a 90% blockage or an 80% blockage. Let's get him to the bypass arena real quick, although he's stable or maybe in many cases asymptomatic. The problem with that is this. So here's a 58-year-old gentleman who presents with an acute inferior wall myocardial infarction. And this cath was done with intravascular ultrasound. And you could see in his mid-right coronary artery, yes, he has a high-grade 99% plaque in his mid-RCA. But that's not what caused his acute MI. That's not where his plaque rupture occurred. So as you continue to course up this right coronary artery, look over here, and you're going to see right about 7 o'clock an area of plaque rupture. Not where you would have expected it down here, but up here. And basically, this tells us that we can't always rely on morphology. We can't look at a coronary angiogram and say, aha, this is where the patient's going to have the event 2 years from now. We know that if you have this lesion in your artery, you have disease all up and down the artery. We know that. William Roberts showed this decades ago. And I think that it's important that we truly go after a prevention approach because it gets all plaques, the large plaques, the small plaques, the plaques in our coronaries, the plaques in our periphery, the plaques in our brain. And it certainly lets reserve intervention where it's truly life-saving. And that's in people who rupture the plaque, who are unstable ischemic syndromes, because certainly that is a different disease than chronic stable disease. So this morning, we're going to start with therapeutic lifestyle intervention, which is truly the workhorse of prevention. And we're certainly, this is not a new concept, by the way. Hippocrates in 400 BC stated that it is very injurious to health to take in more food than the constitution will bear, when at the same time one uses no exercise to carry off this excess. 400 BC. We're still talking about it. Well, what is the optimal diet for cardiovascular health? We're going to discuss that today. We're going to debate that today. You know, certainly should we remove saturated fat from the diet and cholesterol from our diet? Does that constitute a healthy diet? That's kind of controversial and somewhat contentious, and that will be debated. And what dietary pattern works to reduce cardiometabolic health? And we do have a new set of dietary guidelines, as you know. So there'll be a lot of discussion regarding this. There's no discussion about refined carbohydrates and especially sugar, which has been a major driver of our obesity epidemic and of cardiometabolic disease. And tomorrow we're going to have Dr. Robert Lustig, who will discuss this, but I don't think there's any question that fructose, sugar, whether it's table sugar, which is sucrose, or high fructose corn syrup, is half glucose, half fructose. And fructose, when you look at the biochemistry, leads to all manifestations of metabolic syndrome. If I had 35 more minutes, I would discuss every one of them and how this works, but I'm sure Dr. Lustig will do that. But one thing that I want everybody to appreciate, and that is that our ancestors suffered from diseases of undernutrition. And if not for adipose tissue, which was a storage area for fat, we would have perished. We would not have survived. And really, adipose tissue saved us from periods of famine and, in fact, starvation. But modern man suffers from diseases of overnutrition. And the very tissue that saved us as early man is now killing us. And why is that? Well, let's look at adipose tissue. What is it? It's a collection of adipocytes surrounded by connective tissue along with pre-adipocytes, fibroblasts, macrophages. And the term adiposity means increase in your adipose tissue mass. Whereas adiposopathy, which is kind of a new term, or sick fat, is actually defined as dysfunctional fat that results from positive caloric balance and physical inactivity in genetically susceptible individuals that result in adverse endocrine and immune responses that increase cardiometabolic risk and promote cardiovascular disease. It's the driving force behind insulin resistance, and it's important for us to understand sick fat or adiposopathy. The adipocyte, when it's healthy, is mainly in peripheral subcutaneous sites, and it releases an anti-atherogenic adipokine called adiponectin. That's the good guy. Unfortunately, when it becomes dysfunctional, it starts releasing these pro-atherogenic adipokines, and including PI1, prothrombotic, TNF-alpha and interleukin-6, which is pro-inflammatory, leptin, which although is a satiety hormone, it has deleterious effects on the periphery, promoting all aspects of metabolic syndrome. All those go up in a dysfunctional state. But so where is fat stored? The majority of your fat, 80%, is in your subcutaneous tissue, your peripheral subcutaneous fat. 20% is in the belly, it's visceral fat. And what we know is that visceral fat is more likely to be metabolically active and dysfunctional than is peripheral fat. So how does this whole concept of sick fat work? It all starts with we eat too much food, we don't exercise. So that really overwhelms our adipose tissue, and it leads to what we call adipocyte hypertrophy. The adipocyte expands. Now, it's got one of two options. It could either send a signal for recruitment of pre-adipocytes to come in and handle the excess fat load, or it'll continue to expand, especially if the caloric load is acute and chronic over time, and we'll have failure of adipogenesis. And as a result, this leads to increasing adipocyte size, it leads to intraorganelle stress, and stress on the endoplasmic reticulum. It throws out proteins that contribute to insulin resistance of the adipocyte. And once there's insulin resistance, we take the brake off of a lipolysis, we generate free fatty acids, they then leave the adipocyte, hitch a ride on albumin, and we're off to the races. Why are we off to the races? Because fat cells that release free fatty acids are actually toxic to non-adipose tissue. Why? Because the breakdown products include diacylglycerol, acyl-CoA, and especially ceramides. It leads to tissue dysfunction as well as apoptosis. So we develop what we call lipotoxicity. These free fatty acids, if they go to the pancreas, it could damage the beta cells, leading to diabetes. It can end up in skeletal muscle, leading to skeletal muscle insulin resistance. It can go to the liver, leading to fatty liver and hepatic insulin resistance. It could end up in the heart, leading to myocardial steatosis, and it could surround the blood vessels. Perivascular fat leads to inflammation, endothelial dysfunction, and at the end of the day, another cause or increased risk of atherosclerosis. So weight gain leading to metabolic disease is most dependent upon how fat is stored, whether it's the more healthy adipocyte proliferation versus adipocyte hypertrophy, and where fat is stored, whether it's subcutaneous peripheral fat or visceral fat. Now, we also know that when we mobilize free fatty acids and those free fatty acids go to the liver, our liver pumps out, packages those free fatty acids into VLDL as triglycerides, and we have triglyceride-rich VLDL particles, which then exchange that triglyceride for cholesterol with LDL and HDL. And when LDL and HDL are acted upon by hepatic lipase, we end up with small, dense LDL particles that we discussed, as well as small, dense HDL particles that are less functional. And not only that, we often get dissociation of ApoA1 from the HDL, which is cleared by the kidney, so our HDL number goes down, particle number goes down. So when you think about it, certainly adiposopathy could lead to abnormalities of glucose metabolism, leading to insulin resistance and diabetes. It can lead to hypertension. The adipocytes also release angiotensinogen, increase in our blood pressure. It could lead to atherogenic dyslipidemia, all of which increase our risk of atherosclerosis. So there is a concept, there's one of the things that people say, well, what about the obesity paradox? And the obesity paradox is defined as not all overweight patients develop metabolic disease, and not all patients with metabolic disease are overweight. But this paradox is less paradoxical if we understand and appreciate that adipocyte function, as reflected by waist circumference measurements, is more predictive of who's going to develop increased cardiometabolic risk than is adipocyte mass as reflected by body weight or BMI. Very important concept. And this has been shown in a number of studies. The very large Interheart study with Salem Youssef as the leader of over 50 countries involved in this, they noted that waist circumference was more important than BMI and should be utilized in our clinics. And by the way, I went on eBay the other night, and they were selling a measuring tape for 1 penny, and it included free shipping. I have that slide, which I'll bring up, but which makes measurement of waist circumference and the tape measure the most cost-effective diagnostic tool in the history of medicine. So we need to start doing this, and the old saying that waist loss trumps weight loss. So a couple ideas of how this paradox plays out is the ethnic obesity paradox, where Southern Asian Indians, for instance, they're certainly not, they don't have an obesity epidemic. They tend to be normal body weight, and yet they have a tremendous increase in cardiometabolic risk. Why? Because they're genetically predisposed to adiposopathy. And as a result, they have an increase in insulin resistance and increase in cardiovascular disease risk, despite the fact that they're not overweight and their BMIs tend to be normal. Another very interesting paradox is the gender paradox. Now, women carry around twice as much body fat as men, yet they're protected, as I said, up until about menopause. Now, why is that? Because the body fat in women tends to be pear-shaped with a gynoid distribution of their fat, mainly in subcutaneous gluteofemoral fat distribution, the more healthy type of fat distribution, as opposed to men, which have more of an apple-shaped fat distribution, mainly in their belly, the visceral fat. Now, interestingly, when women hit menopause and estrogen levels decline, guess what? We get a shift of women to more of the apple-shaped android pattern of body fat, and I think it's a contributing factor of why their risk increases. So what is the solution for this? And certainly what we've known, the most studied diet with adiposopathy has been the Mediterranean diet. And this was a landmark study by Esposito and colleagues that showed a Mediterranean diet improved endothelial dysfunction, decreased vascular inflammation, lowered body weight, improved insulin sensitivity, and improved the omega-6 to omega-3 ratio. At the end of 2 years in this study, more than half of the participants who entered who had metabolic syndrome no longer had features of metabolic syndrome. It works. Also, Martinez-Fernandez and his colleagues noted that marine omega-3 fatty acids can attenuate adipose tissue inflammation and dysfunction. So these are our concepts that are so important because we can manage and handle. We see a patient in the office who's got a big belly, who's got high triglycerides, low HDL, impaired fasting glucose. We should spring into action. Get these people on the right diet. Get these people exercise. Explain to them that it's far better to get this, right the ship now than to wait until you have a sudden and acute event, which you may not have a warning prior to that. And also get them to exercise. This was a study by Peter Kaczmarzyk and colleagues, which looked at people with metabolic syndrome and noted that even if you have metabolic syndrome, you have a better outcome, lower mortality than somebody who doesn't have metabolic syndrome but is unfit. So low fitness is deadly. And unfortunately in the United States, as we're going to learn this morning, that one of the things that is so important is to achieve fitness. So proper diet, proper exercise, we'll talk about stress management, and all of that becomes critical for us to be able to keep people out of the hospital and certainly keep them healthy. So in order to stay on time, I'm going to summarize that we have two roads to walk down in our battle against cardiovascular disease, and I call it the roads to prevention. The first road is a dead-end road. And what's a dead-end road? It's business as usual. Yeah, let's just use the standard lipid profile, despite the fact that in the Friedwald equation, where the estimated LDL cholesterol is notoriously unreliable in people who have obesity, insulin resistance, adiposopathy. And let's, also in the dead-end road, basically as the patient's leaving the door, just say, oh, by the way, you might want to exercise. We've got to be more passionate. We've got to be able to tell the patients, look, there's a reason why we're recommending this. And you don't have to run in the Boston Marathon. Just get at least 30 to 45 minutes a day of walking. Become more active. And stress management techniques, we're going to hear about mindfulness today. These things work. But dead-end road is to ignore that. The progress road is to get people on the proper diet, the proper exercise program, certainly keep them from exposure to cigarette smoking, certainly get the right biomarkers. And if they have metabolic derangements, let's treat that. Let's clear it up before they have an event, before they have disease. That to me is progress road. That ultimately leads to a long, happy, and heart-healthy life. Thank you very much for your attention.